Lahad, Chairman of the National Council of Public Health. Professor Lahad is a professor of public health and is a family physician, I believe. He heads the Department of Family Medicine at the Hebrew University Brown School of Public Health. I want to thank my colleagues at JPC for facilitating this webinar. Professor Lahad, we start with a short introduction and then we'll open up for Q&A. You are on mute, everybody, so please type your questions on chat and he will answer them. Either you read them or I can read it to you, no problem. And we're talking about the collateral damage of the coronavirus crisis on the public health. Professor Lahad, please.
I will start with what is happening in clinics and in mother and child clinics, regular clinics and mother and child clinics all over Israel. Basically, all the routine work currently is frozen. Very little is done. Patients do call in, but almost never come in and ask for short advice. All the preventive measures like measuring blood pressure and controlling of glucose, sugar, and of cholesterol is not done for the last 3 weeks or so. Many of the well child visits are not done. Only immunization is going on. But that's one part. The other thing is that patients hesitate to come to the clinic or to the emergency room due to acute condition. And there are already several reports about people that are coming too late, more than usual. It can happen also in other times of the year, but now it's much more happening than usual. So that's two damages that are obvious, that we are not doing the routine and that we are not treating well the acute situation. There is a third collateral damage, and that's the future. In the future, what will happen to all these people that are losing their jobs, the unemployed people? It's not only a matter of money and economy. As there are reports all over the world and also in Israel of increased mortality between people that are unemployed. And it almost can be measured. There is one study done in Europe, but it's collected data from all countries and regions in Europe for 12 years that you can calculate what is the increased mortality due to unemployment, and it's not neglectable. And we think that, I say we because we are several people that have the same idea, that all this need to be addressed already today and to take into consideration. And we may say we are willing to increase a little the risk of the corona to prevent other things from happening.
How do you do that? What is a practical way to do it? Yeah, please go ahead.
So I will not be the first and not the only to say that putting all Israel under freezing everything is a thing that you can do for a very, very short period of time. 2 weeks, 3, perhaps not more than that. And you need already to look on the way of going out from that. And the meaning is increase employment, letting people to go to work, letting people to open businesses, and preventing the unnecessary thing. All the unnecessary and essential gathering should not happen, but all the things that run the economy should happen. That's on the last point that I spoke. For the others, is starting to build the clinic already with ideas that they need to work for a long time when Corona will be around. Even if we will control the Corona, we will have 150 new cases a day for a long time. That's happened in South Korea. That's happened in many, starting to happen in other countries. The only one country that it didn't happen, almost didn't, is China, where they were able to complete control it. But I'm not sure that it's 100% correct data. So we need to start to build the clinic to work under situations that the Corona is around and we are still working, which means that there will be probably 3 levels of clinics. There will be a clinic for regular people, regular condition, people that have no fever and no other symptoms, and that will be one level. The second level will be for all the acute respiratory condition. Probably will need their younger staff, because the staff is also under threat from the Corona, and a physician or a nurse that is 65 years old is at high risk too. And a third level of clinic will be for intervention. But this needs to be addressed already. We cannot wait until we will start to think about opening. This needs to be arranged already now, or probably 2 weeks ago. But we need to start to build it up. Including this is opening the World Child Clinic, for example, but many other things at the same situation. It's for children that are healthy, and they can be seen in clinics. You may need to spread the visits with some lives 5 minutes between one visit to another, to reduce the waiting time in the waiting room, but they should go back to work.
So basically what you're saying is that all the attention is now on containing the coronavirus and on reviving the economy, but very little attention is put on the collateral damage, on what the damage of people not going to clinics, people staying at home, the stress, etc.
Completely correct. And I think that it's a mistake. It's too much of a military way, looking on one target. We need to win the Corona. It's a little more complex. We need to win the Corona, but we need to leave the other system around us alive too.
Professor Lahad, there's a lot of talk about coronavirus offering us opportunities to re-examine current institutions. I guess you're guessing where I'm aiming at. The whole concept of a clinic that you have to go there, I mean, why not do it over Zoom, for example? Saves time, more efficient, can be done easily, but you're still holding the concept of the old clinic.
Already about 2 or 3 years ago, the Israeli Association of Family Medicine had a meeting to talk about non-conventional patient-physician relationship or visits. And we started to address this issue. It's obvious that big part of our work can be done without the actual physical meeting. But let's start with the point that you need to know your patient. Now it happens that I do calls to patients that I don't know. It's completely uncomfortable and unsafe. I don't feel that I know exactly who I talk to, and is this patient can take what that I advise or not. That's one thing. So we started to say, okay, you can make a visit to a patient that you know. You need to do a physical visit once yearly or so. Again, it's not wholly that it will be once yearly, but you need to have a personal connection before you start to do it in other ways. That's one. Second, here and there, and it's not so rare, I need to use my stethoscope. I need to use my otoscope to look into a ear. Now, in the future, many of these things will be, I will be able to hear lung noise and heart sound with smartphones that the patient will put on his chest and so on. Currently, it's not there. It can be done, but until it will be done, I need here and there to touch the patient. And a third thing is that there are many things in clinic. Let's take one thing that many people consider, oh, that's only to talk. You can do it via Zoom. A patient that is depressed, it's very hard. I tried to do it, not via Zoom, via WhatsApp with a video with a patient of mine. You don't get the whole story. You don't get the movement. You cannot offer the relaxation for the patient that it's not as being in the same room. Now, it can be used here and there, and it is used here and there, but certainly not for 100% of the cases. So that's part of the rebuilding the system. Yeah, we will move, I don't know, 2/3 of our business not to be with physical connection, but still it will not completely disappear. And last but not least, here and there, that's something that I learned during the year. There are many things that a patient will not tell you until you get and touch the patient. When I start to put the stethoscope on the patient, he or she will tell me something that while sitting both of us on chairs and I'm in front of the computer, they will not tell me this thing. And the very intimacy things will be said when I'm touching the patient. And I need to spare this, that it will happen here and there.
I can second you in saying that my best friend is a doctor, and his patients admire him, not only for his amazing diagnostics, but because he's a mensch. He cares about them. He asks questions which are not necessarily related to their condition, but to their health condition, but to their family or mood or these kind of thing. And obviously healing is not only a physical thing.
Right. And it's not only the prescriptions that you write in the end. The way you get there is also important.
Right. If the future will take family medicine into this direction, that you said 2/3 of the functions maybe will be, does this require another training for the doctors, for the nurses, etc.?
Yes. We're still training the previous step. And you see it with other complaint, and rightfully complain, that physician, when we introduce a computer, about, in most clinic, it came in around year 2000, little before, little after. Many of the physicians, especially old guys like me, had problems keeping the eye connection with the patient and writing at the same time on the computer, and patient are complaining that we are looking on the computer more than we are looking on the patient. Now we are going to do the next step using another technology, and each one of them need to be addressed. First, how you keep a connection, how you keep able the patient to talk, because using a Zoom, for example, it's very easy to you go and on talking and not letting the patient to talk. Then other ways of checking the patient. For example, in this situation, a mother called me, and as 7 years old, I think, her daughter had abdominal pain, belly pain. And she was concerned that perhaps it's appendicitis. Usually appendicitis, you touch the abdomen and you feel if it's hard or not. And I told them to come, they didn't want to come. So I had to think, and I was told many years ago, if a child is able to jump on one foot and do it several times, he doesn't have appendicitis. So again, it's a trick, but there are so many tricks you need to learn when you move from one way of doing medicine to another way of doing medicine. She didn't have the appendicitis. And there are things that we will need to teach ourselves, and then other physicians and students using the new technology.
You know, surely you know the story about the two ladies who every day they go to the sick fund, to Kupat Cholim, and one day one of them didn't show up. The following day, the other says, "Where were you?" And she said, "I didn't feel well." So you think the current crisis will change the pattern of going to clinics? Maybe people will say, you know, I didn't feel well during this crisis, but you know, I took something and I drank tea, etc. People will maybe reduce the frequency of going to clinics.
I'm sure that's right. And anyhow, we're starting with the point that the Israelis are high user. We are not not just in the top, but we are in the upper 10 percentile of users in Western countries of a clinic visit. Our visits are shorter, but the number is big. So this probably will change. And there are many cases that I myself think, trying not to tell, why did you come today? But from your joke, I will take the old little lady that will not come. If she has other friends and family members, perhaps it's good that she will not come. But if that is the main connections that she has, that she is coming to the clinic twice weekly, someone is asking her, are you okay? Is everything is going well? Perhaps we should not stop this unnecessary that are in the end necessary visits.
So the clinic serves other needs, social needs.
Yes, in the end, yes. There are many people that come to me just to talk. They don't want that I will do anything or prescribe anything. They are coming, and perhaps in the new system, we will have a little more time for them, because today, or at least how that it was until a month ago, I had a very limited time for them. Perhaps in the future, I will have a little more.
There's a lot of attention now on the ultra-Orthodox, the Haredi community, and they have their own habits and customs, and they listen to rabbis, sometimes more than to doctors. You think this crisis will change their attitude toward the public family health system?
I'm not sure. It's little too early to tell, but the little connection, I work in communities that have some ultra-Orthodox, but they're the minority, both in my own clinic now, in previous clinics that I work. So my exposure to the ultra-Orthodox community is limited. But even now, I spoke, I didn't see, I spoke with several of my patients that took everything that I told them and went to ask the advice of the rabbi. So at least 3 weeks or a month into the crisis, it didn't change. I'm not sure that it will change in the future. If it will change, it will be due to a disaster, and I hope will not happen, that the advice of the rabbi was so wrong. But I really hope that this will not happen.
The trend in medicine today is to specialize, and gone are the days that the family doctor knew everything, or at least I as a kid, I thought family doctor knew everything. Which direction family medicine goes today with this focus on specialization?
So this is a pendulum which is going one way and the other. I will not say that it's doing many cycles, but we started with a generalist, the classical doctor. Then we went all the way to the subspecialties, and there is some return toward family medicine, not instead of the specialist and the subspecialist, but people find that the specialist gives them a very narrow answer to one condition. When people become sick with different kind of disease, they have a gastroenterology problem and a neurologic problem and something else. There is no one to coordinate and to give a real full answer for them. And so people are coming back a little toward family medicine. We see it also in the number of physicians and in Israel, especially Israeli graduates that are joining family medicine. It's increasing the last decade, I would say. Not enough, but it did increase and significantly. But on the other side, in family medicine itself, there is starting to be subspecialty of family medicine. Generalists that have some subspecialties, usually it's a very common condition. Like there are many family docs that became specialists in diabetic, not in endocrinology, but in specific one disease that it's very common of diabetes, or family physicians that went into being specialists in hypertension and other things like that. But so there is some combination. One thing is patients are coming back to the physician, little more physicians are coming to family medicine. On the other side, few of the family medicine doc are going to little more narrow area.
My granddaughter is a paramedic in the military, and I asked her, "What are you doing?" She says, "I'm teaching doctors, civilian doctors, how to do this and that." I said, "What? You're teaching heads of departments?" I said, "No, yeah, they're great at what you're doing, but they know nothing about something else."
Correct. So that I will take it to two. First, she's right. If there will be a resuscitation, and especially if there will be a resuscitation during trauma, she will probably handle it better than me. So in this, she is completely right. On the other side is that when someone is coming, one of the advantages that I have as a family doc is someone is coming to me with a complaint or a symptoms that is not going into one direction. I know how to check a joint, and I know how to check the lung, and also to hear and think about depression or other psychological stuff. And that's the ability to combine. So I know a little on many things, while others know very deeply in one area.
To wrap up this interesting webinar, do you have actual data on the collateral damage, or it's just a question of assumption and feeling that people are suffering?
So, as I said before, the data that we have is on unemployment, and that's from studies that have been done. And when unemployment is going up, at the beginning there is no increased mortality, but we are not at that range already. In Europe, for every 1% increase in unemployment, there is 0.4% increase in mortality. So if there are about 50,000 people that die a year, there is an extra of about 200 for each 1% increase in unemployment. So this we can measure, assuming that Israel will behave like Europe. We don't have a specific measure in Israel. The other is more the impression that we will need to look later on data, what happened. I didn't see the original data, but I will cite Dr. Boaz Lev, which is the head of the Tzatam, the team that deal with controlling of the corona. He said that the data from China showed that in the province where the corona started, during the time of the corona, the extra number of deaths, cases not attributed to the corona was bigger than the number of the specific corona cases. So it seems that there is a damage, and it have been shown in other places, not yet in Israel. I don't have the Israeli data.
Okay, so we'll have to need to wait for the data to surface. Professor Lahad, I want to thank you very much for interesting talk. And I want to draw your attention to our next webinar tomorrow, 5:15 p.m., when we host Mr. Yitzhak Herzog, chairman of the Jewish Agency, who will speak about the plight of Jewish communities worldwide under the coronavirus and what Israel and the Jewish Agency can do to help. Thank you very much for being with us.